and welcome to our session today. I'm just going to do a little bit of housekeeping, and then I'll do an introduction, and then our brilliant panel that we have here today will introduce themselves. So just to remind you that the meeting is being recorded and will be available on YouTube in due course. Please do use the chat function to comment and share your insights and ask questions, and there will be a chance to ask questions towards the end as well. There will be feedback forms sent out after the session, so please do complete those. And if you are talking about this session on social media, please could use the hashtags Thrive by Design and LeadsDigi21. So in response to the COVID-19 pandemic, the whole health service really had to act and adapt and innovate and at pace in crisis, in the face of really extreme conditions, in order to safeguard the health of the population. And as uncertainty around COVID remains, so do all the signs of us overreaching planetary boundaries and a looming ecological disaster. So the NHS has committed to achieving net zero carbon emissions by 2040 and getting its suppliers to achieve net carbon zero emissions by 2045. That in itself is a big task, but is it actually really enough? If we look a bit deeper into the root issues, are we simply tinkering with the deck chairs on the Titanic? Should we be fundamentally rethinking the way our whole society works? And what do we actually need to rebalance the needs of society within safe and healthy planetary boundaries? So there are lots of sort of new economic models emerging, really transformational models emerging, such as Kate Raworth's donut economics, the circular economy, regenerative approaches, and so on. And coming a little bit closer to home, how does all this fit in with health and care? The NHS alone has 1.3 million staff, 3 million volunteers, and pre-COVID, we were treating 1 million patients every 36 hours. So a massive sort of connection with people. And how do we use that influence to raise the climate crisis awareness and mobilise actions to adapt and innovate? So there's lots of questions there for us to contemplate today. And as we look ahead to COP26, this session is going to explore what can the NHS learn from that from COVID-19 to help play its part in mitigating its own carbon impact and wider impact, and also to influence others. So specifically today, we're going to look at what more can we do to act, adapt and innovate. So without further ado, that's enough from me, I think. I'd love to get our brilliant panel to introduce themselves and what their interests are here. And I'll start with Alexis, who's on my left on the screen.
So, morning everyone. Roger, you're going to ask me a question so I can get me started.
I'm going to ask you a question in a minute. I'll just get you to do a round of introductions.
Oh, right. Okay, fab. So I'm Alexis Purcell. I'm the Environmental and Sustainability Manager with Yorkshire Ambulance Service. I'm also the Net Zero lead for the ICSs, the Integrated Care Systems, that are being set up in Humber Coast and Vale as well.
And Ben, you're next on my screen.
Yes, good morning, everyone. Hi, I'm Ben Tongue. I'm the Sustainability Lead at NHS Digital. Chartered environmentalist working hard to get sustainability and climate resilience embedded into our digital service design.
Lucy?
Good morning, I'm Lucy Brooks. I'm an anaesthetist by background and anaesthetic registrar, and I'm currently undertaking a leadership fellowship in climate change and anaesthesia for Health Education England in Yorkshire and Humber.
And Kathy.
Hi, I'm Kathy Scott. I'm Deputy Chief Executive of Yorkshire and Humber Academic Health Science Network. We try and get innovation into the NHS more quickly. I also lead on environmental sustainability and healthcare innovation for all 15 of the AHSNs.
Brilliant. What a wide-ranging sort of set of perspectives we have here today. So I'm really looking forward to this conversation. I'm going to start with Ben. And I've heard you talking about this before, and I think you've got a brilliant and very educated sort of understanding of the extent of the problem that we're dealing with here. And I'm going to ask the sort of bit headline-y question about, is COVID-19 the warm-up? and could you sort of share with us just a little bit of your knowledge around the extent of the problem that we've got to deal with here?
Yeah, sure. Thanks for the really broad question. I could probably fill an hour up with it, but here we go. So, I mean, just quickly so my NHS Digital are the kind of the main data and digital service provider to the health service. COVID-19 has very much been a warm-up from my perspective on how the sector can adapt rapidly to disruption events. So there's been a huge acceleration in the digital transformation. We've had massive uptick in NHS mail, in the use of the NHS app, with, of course, the vaccination programme and dealing with that at scale, involvement with track and trace too. It's had its ups and downs, but overall it's been a very supportive element to the pandemic. So it's massively changed our work and really sort of challenged us to think about organisationally how we can deal with disruption events. We've done some interesting analysis too on the whole hybrid working thing that's come out of COVID. Interestingly, it's not shown the clear carbon savings that are often been touted for it. It's more or less carbon neutral when offsetting home energy use against commuting. So, that's an interesting finding that piques a lot of people's attention. But I'm going to actually zoom right out now and answer, the question that you really posed here was, so, is COVID a warm-up act for the health service more broadly? So I'm taking off my NHS Digital hat really now with this response. Yes, it very much is. We have a huge range of climate-related issues in the pipeline. Some of those are pandemics, which is why COVID is directly related. There's still debate about whether it was an ecologically caused event or not, but the majority seem to think it is. Even if it wasn't, we're expecting to see more pandemics. We're expecting to see more infectious disease. We're expecting to see supply chain and energy security, as shown in the latest UK Climate Change Commission's risk assessment. And that's all on top of all of the, the first order local impacts like floods and storms and heat waves and all those things which are more being, fairly well thought about already. And I know there's a session that Alexis might want to mention at 12:30 today that's looking at some of that kind of stuff. So yes, it's a huge disruption, highly relevant, and there's so much that I think can come from it. So it's shone a light on health inequality. So at NHS Digital, I'm working with Ros to think about how can we make sure that we're factoring in digital inclusion properly into our design, so we don't leave people behind in the move to virtual treatments. That's a really practical thing, but for me, it's so much of a bigger conversation. For me, we're still in the situation of storytelling around the climate crisis. The climate crisis is still, although we're starting to see little bits and bobs poking up, they're not little bits and bobs to the people involved, but in the news cycle, we're getting big flood events around the world, heat domes in Canada, all of this stuff. We're starting to see the symptoms of climate change now. But still, most people in the UK aren't feeling that on a regular basis in their lives. So we're still in the position of having to kind of storytell to get people to understand that. And I think the frame of the environmental crisis being a public health crisis really can't be used enough. It really is uniquely powerful to our sector. And there's not many sectors that have got that kind of direct risk-related link to their core business. And it's a great way of getting executive attention, I think. I think we need to be moving more to a resilience framing, a precautionary framing. CO2 reduction in a resilience framing is one of the levers for resilience. It's not the be-all and end-all. And it gets most of the airtime at the moment in the sustainability debate. I think that we have an amazingly powerful route potentially in the health sector to engage with citizens. We have an almost unique engagement route if we chose to use it to talk to citizens about getting ready for what's coming in the future, and the best ways to do that. And is it our responsibility to start thinking along those lines is, for me, a really big question. I think that we're, just as a final thought, it's a completely random response, I know, but we need to be thinking as well about how to really start to manage co-benefit and trade-off between different areas. So there's some clear co-benefit often between, a simple example in the carbon agenda is how to, saving energy saves money. There's a co-benefit there. With trade-off, there's obvious trade-off between climate change mitigation and resilience. For, the most obviously talked about ones are things like housing insulation, which helps to deal with lowering energy demand, but causes problems with heat waves. In the digital space, where I am at NHS Digital, there's trade-offs between those mitigation and resilience in terms of how many times we duplicate our data services. So if one of our data centers gets hit by a flood, then we've got a backup one that we can go to. So there's an immediate one there. But there's trade-offs between all kinds of organizational objectives. And we work within a cash-stretched, resource-stretched health ecosystem. And until we can get a really solid handle on this kind of multi-criteria analysis kind of thinking, I do think that we're going to be struggling to get this agenda up as high as it needs to be because of the long-term nature of it. And it's not as real as many of the business issues which have to get discussed at, which could affect the business in the next week or something. So there's a slightly rambling answer, and happy to pick up any of those points.
Yeah, and before we move on to the sort of next big question, well, all these questions are big questions, to be honest, but I'm really interested in that co-benefit and trade-off sort of area, and I want to open this out to everybody actually. What do we currently have in place, and what do we need in place to start actually making decisions, about the co-benefits, about the trade-offs, because we're going to have negotiations, aren't we? We're going to have to, and that's, we're already in a society that's quite sort of divided. How do we sort of move forward together on this and make these hard decisions that we've got ahead of us?
So I think that one of the things we think about when you're talking about trade-offs and negotiation is what you consider as valuable. We need to be thinking more about what we'd call the triple bottom line here. So rather than only considering financial costs, which is often the trade-off with these things, we also need to include into our value assessment social benefits and social costs, and environmental benefits and environmental costs. I don't think we can any longer sit around saying that the only things that matter now are money. We need to reframe what we think of as important, both for our organisations, but on a wider scale for our economy. We need to move away from the idea that growth is the only good thing and the only positive thing. So I think when we're talking about trade-offs, as I say, making sure that we consider trade-offs across the board, not just financial ones, is really essential.
Absolutely. Does anyone else want to add anything?
Yeah.
Okay, Kathy.
I absolutely agree with what Lucy said, and when we're trying to introduce new things that help this agenda, often the conversation starts around how much does it cost, are there any savings to be made, and if there aren't, people are less interested. But that really needs to change. And the other thing that needs to change is the culture we have where you can only do something if you know it's going to work. Some of this stuff is new, it's different, it comes with a level of risk of failure, and that is not necessarily a bad thing, because we learn more from failure than we do from success. So having a culture where that is encouraged really needs to be in place, otherwise we're not going to change very much.
Ben, this is reminding me of the tool that I think you briefly mentioned just now, which you're trying to develop, which is covering kind of some of that, isn't it? So a mechanism by which we can actually, almost with figures, or as close as we can get, actually make these decisions. So I think that's a really clever idea.
Yeah, just to elaborate on that slightly. So this is an invitation to all the participants. I've currently pulled together a working group of people from across the health sector to look at how to quantify the net sustainability and resilience impact of digital health services. So that's from a whole digital health system perspective. So it's looking at offsetting the ICT costs, in inverted commas, against the enabled benefits that we're expecting these to make, and looking at a range of environmental, social and resilience metrics in the longer run. This is a huge challenge, but one of the aims of it is to look at actually enabling a huge lever which we've got in in the government, which is the Green Book, which at the moment talks to exactly this point around trade-off, because what it says is that we should be re-internalising environmental and social externalities, or costs, that environmental and social costs that aren't covered in GDP pounds and pence at the moment, into our business case options appraisals. And very recently, as of 2020, we should also be factoring in climate adaptation requirements into those business case options as well. So we've got some huge levers in play already. It's just about creating easy ways for people to use them, which is really difficult, and that's where we need to get our heads together.
A cultural change is needed now, isn't it? We've got some of those things in place. It's almost like we have got some of the answers here, but now we need to switch tracks and actually use some of this. So I'm going to move on to Alexis now, because I follow Alexis everywhere, online, on Twitter, and all the events she does. And you have got such a lot. You're like a walking directory of things going on around health and the green agenda. You're just incredible. So I'm going to ask you another broad question. What more can we in health do to act, adapt, and innovate?
That's a very nice broad question. Thanks. So in order to act, we need to work as fast as possible to kind of reduce our carbon emissions. And the rollout of what's happening in the NHS will have a ripple effect across everybody, across the entire country. The NHS, for example, has supplies in of about 80,000 suppliers within the system. My internet is very unstable, which is always great. And there you go, there's another example of what we need to work out how to adapt to.
Yes.
So in order to act, we need to work with all of our suppliers. Suppliers need to work with their suppliers, and that kind of ripple effect all the way down through the system. The NHS as a whole, literally today, and I've just received the email, has announced a supplier framework that they've rolled out across the NHS to tackle the 80,000 suppliers' carbon footprints. And by 2030, they will not be dealing with anybody that doesn't have that plan in place in order to eliminate their carbon emissions. So the ripple effect across the world will be huge from what the NHS are deciding now. So acting isn't just about supply chains, it's about what we can do to reduce our emissions now. And so, moving over to zero emission electricity and looking at alternatives to gas. The solutions might not be fully here now, but there's a lot of people within the system that are working on that. Adaptation is something that we also need to get our heads around, and I think we really need to assess this. And within Yorkshire, we are going to be one of the hardest hit, along with Norfolk, for sea level rise. We're already, within the past couple of 100 years, we've lost 30 towns. In the next 50, we're probably likely to lose the same amount through coastal erosion. But we're also looking at the possibility of losing entire cities and moving people within the UK around. So it is something that we're going to have to deal with our own internal migration. So as a health system, we have to be very aware of what the potential is. Whether it happens or not is a different matter, but we need to start building up that resilience within the system. And also we need to start, it's a very pessimistic viewpoint, but in order to be pessimistic, you build in the resilience and you build in the adaptation. We've got 7% of our hospitals and healthcare systems are located in floodplains, are located in the path of rising sea levels. So if we lose this battle, which it's viable if we don't get COP26 kind of elements, if we don't keep it below 1.5, 2 degrees maximum, we are seriously on a trajectory of cramming 60 million people into a lot smaller space. And the pressures that will go with that. So that supply chain resilience comes back again. Say, okay, what are we looking at within our own regional aspect? Petrol crises, pandemics play a really important role in that. We've had some really, really horrendous supply chain issues that are related to COVID-19. So if we take it as a warm up act, we are going to learn an awful lot out of it. And we seriously need to work out what we can do to change that system to become a more resilient organisation as the NHS, but as a country as well.
Is there anything sort of really positive that's happened as a result of COVID-19 that you think, actually, yes, really glad we did that, really glad we've changed, that's going to help us going forward? I mean, that's a question for everybody really, but Alexis, I don't know if you want to.
I think, I mean, some of the things that started pre the pandemic have been accelerated. So the kind of global movements to look at climate change within the health system has accelerated, because a lot of people have been really annoyed by the amount of waste through face masks, for example, and looking at the amount of waste that we're generating through our entire system. So I think things have become a little bit more streamlined in some aspects, but also there's been a great big movement to move the NHS forwards in becoming more green and their aspects. And it's given, for those that aren't on the front line, a little bit of thinking space to kind of work through the challenges that we have ahead of us. There are quite a few positives, but obviously it's a kind of highlighted the negatives of climate change and what we need to adapt to.
I'm quite interested in this idea of like, so if we're gonna, there's going to be floods, there's going to be migration and movement, there's sort of fixtures on floodplains and those sort of things. So we're going to have to become a more flexible, sort of adaptable service, aren't we? And be able to sort of concentrate in one area if there's a big sort of issue there, and so on. So I might turn to Ben actually and talk about, how is digital going to help us with this or not? Are we ready? Are we sort of moving and ready digitally to support that?
I'm just going to answer your first question, and then I'll come on to that. I prepared some ideas on positives that have come from COVID. This is a bit big picture again, but I do think there are some interesting ones that are worth considering, and they're kind of maybe a bit bigger than the health service, but certainly, I think the shock of COVID societally has made us collectively feel more, at risk from future events. And I do think that's a good thing, because it starts to move into that precautionary mind frame. And then off the back of that, I think there are some genuine positives. I think a lot of people have become more connected with their local communities, which is massively important for community resilience. I think a lot of people have got much more connected to nature, which is hugely important, in terms of mental health, in terms of the biodiversity crisis and managing to support it. And I don't know if it's lasted, but one thing that really struck me at the very start of the pandemic was the kind of gift culture that suddenly sprung up, with people really watching out for each other and helping, and going above and beyond what would have been seen as kind of normal before. So for me, there's something about how to kind of make sure that we carry those forwards now that we're starting to unlock again, and make the most of those is really a big question.
I'm part of something called the Better Way Network, and it's a network of people across the country who really care about exactly what you've just said, the power of people to support each other, the power of community to help, in hard times and good times. And it's really interesting. There's little sort of groups of people in different areas who are getting together to try and sort of reconnect and reimagine, what does good look like in your local area going forward? How do we connect everybody? And that there is an element that I haven't brought in yet, around inequalities, isn't there, to all of this, in terms of impact and power to change things and so on. So I might sort of come back to that in a while. What I wanted to do is move on to a really important sort of area of health, which is our clinicians. And why, Lucy, why do you think this should be important to clinicians, and not just clinicians, but our leadership? What should they be doing? What's their role here to play?
Thanks, Ros. So as Ben mentioned, we know that climate change is bad for health and it worsens existing health inequalities. So with this in mind, it's really important that clinicians take a leading in our response to the climate emergency. You know, we're patient advocates, and that needs to go beyond the walls of our healthcare institutions. The World Health Organization is predicting that climate change is going to lead to an additional 250,000 deaths per year between 2030 and 2050. And it's people and communities that have contributed least to the climate crisis who face the worst consequences. Globally, as we've mentioned, there are rising sea levels, and that's going to lead to displacement of millions of people across the world, and it leaves people without shelter, unable to access medical treatment, and it greatly increases the risk of communicable disease spread. So in the midst of a pandemic, this is not something that we can afford to ignore, certainly not as clinicians and healthcare professionals. So the additional morbidity and mortality from climate change isn't only just being felt in distant countries. You know, in the UK, long-term exposure to air pollution is responsible for thousands of additional deaths per year, as well as causing both heart disease and lung disease. And these impacts have a huge increase in demand on hospitals, not only the premature deaths, but stretching our already overstretched NHS, particularly at the moment, whilst we're still recovering from the burden of COVID and looking into winter. This is really something we need to be taking seriously. I think that as clinicians, it's our responsibility to stand up for our patients, but also for our health service and do our part towards improving sustainability. You know, as a doctor, I've promised to do no harm, and we have to take that beyond the patient in front of us and apply it in a wider sense. I think we've got a responsibility to use our platform as trusted professionals to advocate for principles of sustainability, to be embedded both in society and with the public and with policymakers. As Ben said earlier, you know, we've got access to people and can influence decisions in a way that other people just don't have access to. But the NHS isn't just a victim of climate change, it's also a contributor responsible for approximately 5% of our UK carbon emissions. So we need to be doing our part to act to make our own practice more sustainable. So that might be avoiding drugs which are known to be harmful to the environment, or reducing our energy usage by switching off computers and lights and disposing of our waste correctly. But we need to also escalate our concerns up the chain of command into our department and hospital leaders who need to know that sustainability is important to their team. And you asked about leadership. Well, I think we need leaders who foster a culture of innovation and curiosity. We need people who are courageous and they're prepared to back their teams to take risks, even when there's a risk of failure, as Kathy said earlier. I think this is really difficult within the NHS. Failure is often seen as completely unacceptable, and there's a feeling that effective performers don't fail. So we really need leaders who shift their role from one where their job is to prevent failure to one where their role is to promote learning. I think that's a big culture shift. We need people who are going to nurture trust within their organisation so that when they're making changes and innovation comes, the team feel safe to make suggestions and also to go along and be good followers. And we need people who are going to understand the triple bottom line that I mentioned earlier, you know, not only prioritising financial costs, but also thinking about cost to society and particularly cost to the environment. And I suppose above all, we're going to need some money, funding. Innovation is going to require access to funds, and that's all going to be gate-kept by our leaders. You know, money isn't only needed for innovation, it's also going to be needed for adopting change and transitioning to new ways of doing things. You know, even the best innovation in the world won't stick if resources aren't given to embedding it. So I think those are what I would start with, at least.
Yeah. That's absolutely, this is turning out to be a bit of a masterclass. That was a really powerful speech. You almost had me in tears at some point there. Thank you very much for that. I think you also led quite nicely into the question I wanted to ask Kathy. So talking about innovation, and it's, I think I've got two questions, but I'm going to start with, you know, a really broad question, Kathy. So I know you've been doing some fantastic work and you're connected into a network of people and organisations that are doing a lot around adaptation and innovation. So I'd love you to tell us a little bit more about that, some of the practical things that are going on out there.
Yeah, thanks, Ros. So firstly, I just wanted to say I absolutely agree with what all of the other people have said today, particularly Lucy around the role of clinicians, because that's really important, because we have to do stuff differently. We can't, it's that saying, isn't it? If you carry on doing the same things, you'll get the same results, and we don't want the same results. And I think that COVID really accelerated that willingness to change, and there was a big enough threat that the risks were worth taking, and we need to capture some of that cultural change and try and keep it as we try and do stuff differently. And there is actually loads of stuff that's happening in the NHS. People are doing things differently. So if you look across England, there's some research going on around reusing catheters, PVC catheters. Is it safe for the patient? Is it too much of a hassle to do? Does it cost more to reuse than it does to dispose? Because every year we're disposing of over 100 million PVC catheters. So research like that is really important. We're looking at reducing hospital attendance. So there are innovations that keep people out of hospital, because keeping people out of hospital has a big impact, not just on carbon emissions, but also on some of the associated consumables. So we, as AHSNs, we've supported a diagnostic test, PLGF, that diagnoses preeclampsia in pregnant women. So having a certain result means that women who don't have it, and it was thought they might have it, can be sent home. And we calculated the impact of that. And over 18 months, it saved over 1,000 tonnes of carbon from keeping people out of hospital. Reusable PPE. So we've talked about the fact that the amount of single-use PPE that's been disposed of is just shocking. But reusable PPE, the AHSN network has been working with Departments of Health and Social Care and the NHS England procurement people. And reusable PPE saves money. It uses 28% less energy to produce, 41% less water, and when compared with disposable PPE, 66% less emissions to create and launder. So that's something that's going on in the NHS now. It's really popular with staff. There's work going on around green social prescribing to calculate the impact to people's mental health. We know that if people are connected with nature, they have better mental health than if they're not able to get out. There's also some indications that it reduces frailty in older people and reduces isolation. So there's work going on to actually be able to evaluate and calculate the impacts of that, and that's happening in the north. And then bringing it back to Yorkshire and Humber. So in our 3 ICSs, there's so much going on. I mean, Alexis will know far more than I do, but some really, really good stuff. So we were funded by West Yorkshire and Harrogate ICS to set up the first net zero accelerator. So this is a innovation accelerator. We've got 3 products on it at the moment because it's a proof of concept, but these are all products that either reduce waste. So there's a 3D printer that you can sit in your hospital, your pharmacy. It uses biodiverse plastics. It's environmentally friendly plastics. You punch in the number of the thing that you want, it prints it out for you. And the thing I really like is when you've finished with it, you can put whatever it was that you needed back into the printer as fuel to print something else. So it really cuts down on waste. It cuts down on the logistics and the carbon emissions from that. And then we've got two innovations, reduce the need for patients to be seen in a hospital setting and reduce the standard communication with patients through post. It's all done digitally, which brings me on to virtual wards. So that was something really good that came out of COVID. So the appetite to do something different and the need to keep people out of hospital coalesced around virtual wards. So for COVID, it was things like pulse oximetry at home. Excuse me. So you could give a patient a pulse oximeter and the app, and they could record their readings at home. They don't need to go into hospital, and the clinicians can see what's happening because the patient is recording it, and the information from the pulse oximeter itself is being pumped into their patient record. And that means that they could be called into hospital if there was a need. We're supporting something called Tyto Care, which is like a doctor in a box. And this is great because it can be used in so many settings. So it can be used for children in children's wards, so that the parents are given the device, they take it home, they monitor their children, and again, it all goes through to the clinician, and it supports video conferencing with the clinician as well. It can be used for elderly people in care homes, and most recently we're trialling it in emergency centres, so that if you go to A&E and you need to see a specialist, you don't have to go to another hospital, or the consultant doesn't have to come to you. It can be done virtually. And then the final couple of things that I wanted to mention around what's going on in Yorkshire and Humber. There's a project that we're working with GlaxoSmithKline on, and I know industry can be a dirty word, and the NHS, we don't want to work with the pharmaceutical industry because, let's face it, sometimes they have, in the past, they have done some unethical things, but there is a real appetite to work with the NHS. I think things are really changing here, and industry is as exercised about this matter as the NHS and can be a real supporter here. but working with GlaxoSmithKline and Humber Coast and Vale to look at how we reduce the impact of asthma inhalers, which are a real contributor to carbon emissions from healthcare. And then finally, looking at how we reduce the use of harmful gases. Lucy will know all about this, but the HSN network runs a series of learning and sharing events to bring people in the NHS together around particular environmental issues. And the one that we had this week was around reducing the harm from anaesthetic gases. And we heard from Joy Hurst from East Lancashire Hospitals, where they'd really cut the use of desflurane simply by taking the knobs off the equipment and putting them in a cupboard. So by making it more difficult for people to use the harmful gas, people automatically went to other alternatives. She said there was no fuss, there was no bother, people weren't resistant to it. It was just because it wasn't available to them and they had to walk to the cupboard, they chose better solutions. So I think things like that demonstrate that the NHS is doing something different, but the culture change that Lucy talked about, that needs to happen. We need to take the focus off the financial, and clinicians need to be leading the way, because finance directors listen to clinicians. That procurement people listen to clinicians. Other clinicians listen to their peers, and it doesn't really matter what level that's at. If you've got something new, having a clinician shout about it and say, this is great. If it's a midwife, a nurse, a physiotherapist, whatever, having that clinical backing makes a real difference to how willing people are to take up something new. Sorry, that was a bit of a ramble, wasn't it?
That's really, quite a breadth of different types of adaptations and innovations, and also sort of, you were touching on some of the sort of challenges, I think, around partnership working and industry and public sector working together and so on. Really interesting. And I love you. So my boss is the finance director and leads the York Partnership Foundation Trust. So I'm going to go back and tell her what you just said. But, it is true that clinicians do have a really sort of a lot of power in this, don't they? And I'm always really delighted to see the number of clinicians that are really getting engaged in the green agenda. And there's all sorts. There's the what's it called? This Sustainable Healthcare Centre for Sustainable Healthcare, who are doing courses for clinicians, and there's all sorts of networks out there happening. So you're right, and I think there's that power is being switched on. To coin a phrase. There was a couple of things I wanted to sort of ask really, and one was, does anyone else have any kind of innovations and adaptations that you think we should be talking about here today? And then I'll ask the second question in a moment. I'll just wait. Ben, do you want to sort of add to that?
Yeah, I realised that I missed out on answering one of your earlier questions. Was about, you posed the question to me of how you thought digital services can be part of the kind of climate change resilience support package. That's actually something I'm thinking a lot about at the moment. So I'm trying to kind of build a narrative around how digital can be seen as a cross-cutting enabler for societal climate change resilience, specifically to the health service, but I do think it's a bigger topic than that. So it's already seen as an enabler for mitigation and efficiency and carbon reduction, but it's not really seen as a cross-cutting enabler for climate change resilience yet. But I think it's just a maturity thing. It's like we're still kind of working out how to think about some of this stuff. But just to kind of bring that out a little bit, in terms of NHS digital, there's obviously, our systems need to be able to scale quickly when there's spikes in healthcare requirements. So, and we've tested that through COVID, and that's fine, it's working. Telehealth has exploded through COVID, that's obviously digital. And that's a really practical way of supporting people who are experiencing local disruption events. And so pandemic tracking too is going to need to be something that we do. But there's more than that, I think. There's really basic stuff like community support networks. I think that it doesn't always have to be really complicated, just a way of connecting with people who live within a mile of you about what they might need, or if you've got stuff that you don't need anymore, sort of with a circular economy perspective, that kind of thing is really great. And I think it's starting to flourish more. It's been a lot of kind of pent up opportunity in that space for a long time. And that's digitally enabled really. And then there's like bigger stuff as well. So supply chain security has come up a bit recently on this call. And so there's starting to be like plugins now into the gov.uk supplier register from the Cabinet Office has got plugins you can get that track global disruption events. So you can log your suppliers into it, and then it tells you if there's an extreme weather event elsewhere in the world and if that's likely to affect your supply chain. Again, a digital solution, not particularly complicated, just a kind of global mapping exercise. But and then there is complicated stuff, like on our talk, digital session that we did with Alexis with the ICS Lunch and Learn events, we had Microsoft coming along who were talking about AI for Earth. And that's a fantastic project that's looking at, how can AI systems support, for example, people who are trying to grow crops in rapidly changing climates to tell them what they should be planting. Or they gave an example in their presentation around helping pollinators, with the kind of crisis that's around them as well. So there's all kinds of stuff, extreme event forecasting using IoT sensors or smart microgrids for electricity distribution. Energy security is obviously a kind of existential risk for digital systems. So how do we kind of make that secure in non-hospital environments where there aren't backup generators? There's got to be a really big question for us, and one where some innovation is needed. But there's so much, could write a book on it really, I guess. But,
I hope you do one day, Ben.
Yeah, maybe we will one day. Yeah, so hopefully that gives you a little flavour of the opportunity.
Yeah, that's absolutely brilliant. I think one of the things that's come out of this conversation, I think, across the whole thing, is about culture, embedding, all of that. Because I think clearly we have got a grip on what the issues are and the magnitude. And we've interconnected it. We know it's a complex system issue. It's not just a one little issue over here, and it's going to take all of us to resolve it. And we've got all these brilliant sort of innovations and ideas. We've got clinical leadership. We've got contact with practically everyone. We've got a big sort of part to play in the world as well. So we've got all the kind of answers, if you like. So what is it going to take to really, on a sort of micro scale, embed things like reusable PPE? But also on a macro scale, actually get us all understanding this and all moving in the same direction, and all that fundamental transformational change we need. What is it going to take for us to do that? Embedding in culture. And if you can answer this question, I'm going to beg you all to run for MPs and Prime Minister. But it is a big question I'm asking you. But some tips really around cultural change. Lucy, you're the brave one to go first on this one.
Yeah, I know. I thought I'd get in there with something easy first. I think this is a huge question, and I think in truth we don't know the answer. There's loads of theory about behaviour change and cultural change. But I think it's a really interesting question as to why it's not happening already. For example, in my own specialty in anaesthetics, we know that some of the drugs we use are significantly more harmful to the environment than other drugs, but people are still using them. And why? And I think we actually don't know the why. And I think if we don't know the why, it's really hard to then change behaviour. I think that in terms of a micro level, nudges to people. I mean, Kathy mentioned how the team in East Lancashire had taken the desflurane vaporizers off the machine, and that just sort of deterred people from being bothered, really. So we need to make it really easy for people to do the right thing. And I think that's the first step. So whether that's removing from clinical practice harmful things that are harmful, or rather making it more inconvenient. So, desflurane is an example in my anaesthetic practice, but it could be things like removing single-use gloves from areas where single-use gloves aren't really needed. The Great Ormond Street Hospital did a big campaign to reduce the number of single-use gloves they were using just through education. Staff were using them at times where it wasn't really necessary. So I think basic education and making doing the right thing easy are the first steps at a micro level. And at a macro level, I think some of it's about pressure. It's about everybody joining together, finding our allies, and calling on the powers that be to make change. And that's really hard. It is really, really hard.
Yeah, I'd like to come in on that again. I agree with everything that Lucy says all the time. I have to talk about some other stuff, Lucy, and see if I still agree with you. So that nudging is really important. But I think there's like a circle that you could have here. People from the top, people need the permission to do things differently. But people at the top won't be giving that permission unless there is enough call for it from people at the bottom. So the more we do, if we all do one small thing, that could be huge, and that puts the pressure on the people at the top to give permission, so that more people feel they can do that one small thing, and it snowballs from there. I mean, that's really simplistic, because fundamentally some of what is at the bottom of people not changing is because people don't like change. It's scary, it's difficult, it requires them to walk further or whatever. It's people are, you know, I've seen it even in me, and I'm convinced of the need for this. I will sometimes go the easiest route and act myself, because actually it's not the best route for the environment. It's just easier, and I don't like change.
I've asked the audience if they would like to ask questions, and please do, if you have any questions, put them in the chat. There was and somebody's put a question in Q&A and been really good. So I'll ask the person who actually used the Q&A function question first. And they're sort of quite technical, I think, in some ways. Can multi-server in regular use for speed with built-in redundancy? Oh, I don't understand this question. Can multi-server in regular use for speed with built-in redundancy that will only slow down the performance? Does anyone understand that?
I think it's quite a technical question that I also don't understand quite what it means, but Bob and I have been emailing each other during this call, and I hope we're going to have a chat about, he's got a lot of crossover with what I'm thinking about in terms of hosting, so we're going to pick all that up.
Thank you. Sorry, Bob. Yeah, I'm not the most technically minded person. And there is another question, and it's about procurement. I don't know if you spotted it, but it's like, basically, how can procurement teams be supported to set the weighting for the different things they could be buying? So, you know, some sort of, freedom to sort of, change the way and be, good practice in terms of procurement. Hard question, Alexis.
So there is some social value stuff that is coming through with the procurement stuff. I'm not a procurement specialist at all. It's just everything. The calls that I've been on recently have kind of indicated that there's going to be a social value weighting, which will be compulsory. It will be for everything over £5 million kind of now, and then it'll be embedded in everything across the board. So the social value aspect will look at something that will be locally procured, ethically procured, modern slavery, and have all of those elements embedded in what you procure and how you procure it and where it comes from. Ben, are you coming in?
Yeah, just on top of that, there's a thing called PPN 06/21, bit of jargon for you there, public procurement note from June this year, and it's basically looking at saying that we should only be working with suppliers who have net zero carbon action plans in place as a pre-qualification question, which is really proactive and great. Yeah, it's looking at mitigation rather than any resilience or adaptation stuff, but it's a step in the right direction. And the Greener NHS team are saying, although it only applies to bits of government at the moment, of which NHS Digital are one as an arm's length body, but not frontline care. But the Greener NHS team are going to be duplicating it to apply to frontline care from 2023. So those of you in the audience who would like to get a running start on that, who are working in the NHS, frontline elements, take a good look at it, because it'll be coming in down the pipeline.
Yeah. Okay, I got two questions. One, has anyone done any research on hydrogen as a byproduct? Alexis, were you nodding there?
So there's literally 2 days ago, the Hydrogen East was launched, which is basically a network of all the kind of gas networks. So Cadent, Northern Gas Networks, and another. And they will be connecting putting a hydrogen pipeline in, which basically is utilising everything that's in the stuff within the network anyway. But they will be looking at, rather than blue hydrogen, which is methane cracked stuff, so it's still a carbon-based one, and with CCUS and carbon sequestration stuff, they'll be looking at working with the Dogger Bank offshore wind farm to look at how to create hydrogen that way. Hydrogen as a byproduct, there is, so over in Cheshire, there's a hydrogen manufacturing process that is from caustic soda. And there are some other, Cathy might have knowledge of other ones in and around the Hull Freeport area. There is some chemical stuff that generates hydrogen as a byproduct as well. So hydrogen is coming, but it won't be in the quantities that we needed for heating and also vehicles as such, but it is part of that process.
Just to mention, I don't know anything much about this, but North Cumbria Academic Health Science Network are partnering up with the local authority, city, region, mayors and so on to look at hydrogen. So if I'll put my email address, Bob, in the chat, and then I can connect you with my counterparts in North Cumbria HSN.
Brilliant. And there's been some really good sort of conversation actually in the chat as well as here in the panel. And there is on the sort of partnership kind of aspect that you brought up there. Rosie has asked a question which I think is really good actually around will integrated care systems help or hinder the triple bottom line with consideration for social and environmental factors, for example, specialising screening services? So that's a really good question. I don't know if anyone wants to answer that. Will they help or hinder? My suspicion in a word is depends, but I'll open it out to the panel.
I think in some cases that they will help, especially since every ICS now has to have a net zero lead embedded, and there are procurement teams that, especially myself, I've tasked a procurement task force to look at this as part of the green plan for the ICS region. As Cathy was saying, and Lucy was saying, it is about how you get it embedded and how you get people brought in on the agenda. So very much a case of those social and environmental factors have to be in there, but we're getting it from the top as well through the PPNs and the greener NHS stuff, that it has to be embedded. So the ICS has to mandate it. So therefore a trust has to mandate it, and somebody at the bottom will have that automatically all the way through the system. How much gets embedded that quickly, I'm not sure, but it will have to be an obligation.
Mm-hmm. Does anyone else want to add to that?
Only to use West Yorkshire as an example, where they have 10 big ambitions, and one of those is around environmental. They've got other of their ambitions around health inequalities. It's really focused, the work of the ICS, around those areas. So where there is a message given by the top, it filters down and it becomes a priority. So if ICSs are doing that, then absolutely a help. If they're not doing it, then I think they're just neutral. I really hope that none of them will actually hinder this agenda, because that would be a tragedy.
I think the hope, I mean, the hope really is that integrated care systems are not just about the NHS. They're bringing in local government, and they're bringing in the voluntary sector, and they're supposed to be bringing in the local population as well. And this matters to those sectors. It matters to all of us. And as the sort of national sort of narrative changes, that will, if integrated care systems are not already prioritising, it will put pressure on them to prioritise, I think. And local government are accountable to local people, so where they're feeling things like floods and heats and so on, and where it's going up the agenda, let's talk about where I live, save the trees, for example. There's going to that hopefully is going to sort of bring that agenda into the integrated care systems as well. So I hope that they will help. I think overall. We're sort of we've only got 5 minutes to go. I can't believe that. This has been, I can't believe how much information and knowledge and debate has happened today. So really, thank you so much, everybody. I wanted to we've touched on sort of inequality, I think, and we have mentioned it, but I feel like there's a whole nother session we could do around that. How do we make sure that we do all of this, but we keep our eye on the fact that we have pre-existing inequalities. And as we saw through COVID, that they were exacerbated by COVID, just, everything that comes along, floods, whatever happens, there's going to be an extra sort of thing to think about there. And I hope that all our policies and all our activities consider that. Mark Clayton's put pest power would be another avenue for influence. Absolutely, I think. Now, I've asked all the panel to think about giving a sort of takeaway gift to our audience today. It's always nice to be sort of left with something. And I think we're sort of thinking about, what tools or interesting platforms or events that are happening, that kind of thing. So I'm going to start, and then I'm going to go around and ask each of our panel, one, if you've got anything left you really want to say that, and two, to share your gift. And my gift, I've got two actually. It was going to be the Ubiquity University, which is a global sort of university or movement that's really thinking about this stuff in a transformational way. And what they've done is created an MRA, which is the environmental equivalent of an MBA. It's brilliant. So I'm going to put the link to that in the chat. But as I was listening today, I was also thinking about another an organisation that I used to work for a short while, called the Sheila Macaqueny Foundation, and they are experts in campaigning and social change, and they have got an awful lot of tools that would be really useful to people working in and around health who really want to understand how to make that change, that cultural change. So I'm going to put that link in the chat as well. And I'm going to hand over to Kathy, because she's doing a lovely big smile there. So I'm going to hand over to Kathy to share her gift.
Thank you. So mine was something that probably people may already know about, but it was new to me. So TerraCycle run a free recycling program where they put sites, they ask for volunteers to run sites, and they recycle stuff that is hard to recycle. So things like blister packs for drug packaging, you can now take down to a participating super drug. But when you look at the list of things that are there, and the downside is these are often operated by industry, so they are limited to their particular product. So, but you can recycle things like Baby Bell packaging, or marigold rubber gloves, L'Occitane beauty products, and so on. So there's loads out there. There will be a point near you where you can take your stuff and recycle it that would otherwise be thrown away. And if you can't get to one of those, you can email TerraCycle and they will send you out a label to print at home so that you can send your stuff in by post. And I thought that was great, and I think we need more like that. And I'll put the link in the chat. Thank you.
Ben, do you want to go next?
Yeah, okay. So I'm going to share some links and offer some support that we've tried at NHS Digital as well. So I think that the only way that we're going to make the change that we need is by switching to a resilience framing, and to somehow, by hook or by crook, get sustainability and resilience up there as a kind of top tier mandated organisational objective across the sector. So it's something that can't be a bolt-on anymore. That's difficult because it's a lot of engagement that needs to happen on it, and a lot of persuasion. So I've chucked some links into the chat there. There's some great resources from Chapter 0 who look at climate risk, some outreach ideas from Climate Outreach around addressing the public on climate risk and adaptation, Climate Psychology Alliance, and another organisation there that are looking at how to start to kind of engage on these topics. I think it's so important, and one of the things that we've tried at NHS Digital is we've trained our mental health first aiders network to support colleagues who are suffering climate distress, because if you really